if we could get Dr. Pederson, please.
Hi, everyone. I'm just going to get my slides up here. One more second. Can you guys on the panel see Chinwe, Dr. Obinwa, can you see the slides okay?
Yes, yes, we can see. Thank you.
Okay. Hi, everyone. Such a pleasure being here with this community, which is so special because it's so needed and so timely. So my name is Aderonke Bamgbose Pederson, and I am a psychiatrist and faculty member at Massachusetts General Hospital in the Department of Psychiatry at Harvard Medical School. And I'll give a tad bit about my background here. So I'm originally from Nigeria. I moved to the US about the age of 16. Something that's so important to me when I approach the lens through which I look at health disparities, mental health disparities, comes through my lived experience as someone who lost both of my parents by the time I was 17 to lung cancer, and experienced firsthand the impact of health disparities when it comes to the intersection of what it means to be Black, what it means to be a migrant in a new country, in a new community, going through an illness where you have limited access to healthcare. Most of my education and training was at University of Chicago and at Northwestern. Both of those places are in Chicago, Illinois, here in the United States. The core themes that drive me: God, family, community, the Black community. Those are my mantras. When I think of our mission, and I think we all have things that drive us, why we do what we do, how we approach our patients, how we approach our communities, and all of the little things that make it meaningful to have 50 notes at the end of the day to write, and the drudgery sometimes of what it means to be in healthcare, no matter where you're coming from, whether you're a psychiatrist, a psychologist, a social worker, a nurse practitioner. So my goal ultimately is to contribute to the achievement of equity in health and wellness, but to also think about that in the context of socioeconomics and how all of those things intersect with one another and contribute to health outcomes. And ultimately, if I could use 4 words, to dismantle anti-Black racism. And I'm specific here saying anti-Black racism because I think sometimes in our DEI efforts, diversity, equity, inclusion efforts, we tend to dilute out the impact of health disparities and health inequities on the Black community specifically. And why do all these things matter? Well, I think Martin Luther King Jr. Said this best. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So it's one thing to say, someone might not be able to, have the same access to a school system, which we know inevitably is a social determinant of health. But it's another thing in the process of the greatest level of vulnerability people can have when they come into our health systems, when they're hospitalized, whether for illnesses like cardiovascular disease or illnesses like major depressive disorder or schizophrenia. The idea of having unequal care in such a vulnerable space, you can see why even, decades ago, we're talking about how injustice in healthcare is the most shocking, and it truly is inhumane. And that's why it matters, because these are not things that we're talking about because it's just fun to talk about, but because at the end of the day, we're talking about something that is at the level of the dehumanization of human beings, which we see time and time again, just in different forms every generation. So I'm going to talk about mental health and, how that impacts Black people, and everyone has been talking about different aspects of that. I'm going to focus on stigma. So we know Black adults in the United States represent about 13% of the population, but comprise about 20% of those affected by mental illness. And I'm going to kind of tease apart that story for you as well. Some studies show anywhere from 16 to 20% of mental illnesses. So while we might all assume that the prevalence of the lifetime prevalence of mental illness is worse for Black people in terms of just that number, the prevalence, it's actually lower. The prevalence of mental illness is actually lower than expected for Black people compared to Asian, Latino, or Latinx people, and for white people. But where the story really unravels is when we look at the chronicity of mental illness, the severity of mental illness. So Black people have lower utilization of mental health services compared to white adults. Black people experience more severe illness, delay seeking treatment. Certainly there are several issues tied into that when it comes to access to care, when it comes to the ability to have private insurance versus public insurance versus no insurance. But time and time again, every study shows that there is this delay in treatment seeking for a myriad of reasons. And ultimately, I would say the main reason, and many studies show this, is about structural, systemic, individual racism and how that plays into care, regardless of whether you're coming at this from an economic standpoint or purely an access question around healthcare. So a couple other things here. Black people are more likely also to present to inpatient psychiatric units because of that delay in treatment seeking. And that's significant. Let's say if we take, for example, something like the mortality and morbidity attached to mental illnesses, whether we're talking about major depressive disorder or we're talking about the psychotic disorders, because the degenerative effect on the brain, early intervention, early initiation of treatment makes a huge difference. And so this delay in care ends up causing more severe illness. So what is stigma? I think we've thrown that word out. It's more complicated of a term, but the way we use it, we're just kind of talking more generally about it. So I'm just going to add a definition here. So we're talking about the same thing. Stigma is defined as simply as possible as having negative attitudes or beliefs or behaviors, and behavior is key. So stigma is not just about what you think in your head, how you feel, but also what you do with that knowledge or those attitudes in your mind. So stigma is about our attitudes, our belief systems, but also about our behaviors. And I love that earlier the topic of internalized racism comes in, because there's also this idea of internalized stigma, which results in furthering psychological distress. So it's one thing to have a mental illness. It's another thing on top of that mental illness, or to experience mental illness, to have a stigma directed towards yourself, whether that's internalized stigma or self-stigma. There's also stigma that we talk about very broadly in the community, public stigma. And that's the stigma that we tend to talk about when we're talking about our campaigns, our End the Stigma campaigns. So what are the things that influence our stigmatizing beliefs or attitudes or how we view mental illness? One of the things that my research really focuses on is looking at how our cultural belief systems, our religious belief systems, our socioeconomic status, our backgrounds influence the way we look at what mental illness is. And I'll give you an example. Some people, the focus of how they view mental illness might be that people with mental illness, or even themselves, they might be looking at themselves, are weak or lazy. It's self-inflicted. Maybe if you just worked harder, if you just pulled yourself up by your bootstraps, you could just shut it down and stop mental illness from happening. Another way in which people might look at mental illness is through ideas that mental illness is caused by things like demon possession or spiritual attacks. And it's really important that we're thinking about, I see Dr. Obinwa, are you about to say something?
Dr. Pederson, I'm so sorry. Could you increase the slide or put it in a full view? We've been getting requests that to put it on a, to make it full view, it's only taking up half of the screen.
Thank you. I saw you there, and I thought I should probably.
I wish I was techie enough to tell you what to do. I'm not, sorry.
Let me try. Yeah.
Oh, we've got Andre, yes.
Let me try.
Perhaps if it's on presentation mode, we're getting lots of ideas from the chat. I'm so sorry having to interrupt in this flow.
No problem.
Maybe if we just put this the slide, where's the slide function? The champagne glass. No, I'm thinking of that right now.
I think that's it.
Okay, yes, that's better.
Okay, let me know if people are still having trouble seeing it. Okay.
Thank you.
Okay. So when we're talking about things like culture, religion, and all the different ways in which we come at our ideas of what mental illness is. So what I was saying earlier is some people might view mental illness when we're thinking about stigmas around mental illness, that people who have a mental illness are weak or lazy, versus others might view mental illness not so much as weakness or being lazy, but they might view mental illness as something that is caused by external forces. So you're under a spiritual attack. That's why you're experiencing this mental illness. Or you are possessed by an evil spirit. That's why you're experiencing this mental illness. All of those views that we have about mental illness within the community or outside of the community, the Black community specifically, influence our choices of how we think about solutions to this problem. If you think the driving force is more self-inflicted, or you think the driving force is more spiritually based, you're likely to seek solutions around what you think is the cause. And so it's really important when we're talking about stigmas that we're not just generally talking about stigmas, but we're thinking about the content and the characteristics of what stigmatizing beliefs people may have. Racism. So I sort of alluded to this earlier, this idea of, on the one hand, you have a mental illness, but the impact of, for example, disclosure, talking about the fact that you have a mental illness as a Black person is different than the impact on a white person. And we talk about this even in our training. If you're a Black medical student and you go to your supervisors who have no lens sometimes to look at these issues, and you say, I'm struggling with depression, I'm struggling with anxiety. On the one hand, if you're a Black person, you might be viewed as, again, those stigmatizing views might come up. This person is just lazy, or because of the intersectional impact of being Black and having a mental illness versus if you were white with a mental illness, and you're viewed as, you just need help, we just need to support you more, and then you'll be able to achieve your goals. And so all of these factors work together to influence the way in which people, Black people, intersect with the mental health community and with health services, and why there might be a barrier to care. So racism, absolutely a huge issue. We know this when we talk about things like medical mistrust and all of those factors that continue to create these barriers to accessing mental health services. And Hanson Buehler was one of the first people to kind of really put this into words, this idea that stigma in and of itself is a fundamental cause of health inequities. So one of the studies I did was looking at religiosity and stigmatizing beliefs and views among African Americans and Black immigrants here in the United States, in somewhat of a nationally representative sample of about 270 adults. What I'm going to focus on here is the fact that over half of the participants believe mental illness was caused by sin. So about 52% of the participants said sometimes or more frequently, mental illness can be caused by sin. And 2/3 of the participants, about 65%, said mental illness could be caused, and this is sometimes or frequently caused by demon possession. So this is just a breakdown of some of the characteristics and the responses people gave in that survey. One that I want to draw your attention to is this idea that taking medication for mental health is a sign of lack of faith in God. And who better to address those issues than someone who has a lived experience and knowledge of where these belief systems are coming from, and to not, look down on people for having these belief systems, but to know how to address it in conversation between patient and provider. And so this idea that taking medication for mental health is a sign of lack of faith in God, over 50% of the sample believed that this was the case. So again, this results in many ways in lack of access, because there might not be that drive to seek care and that delaying care that leads to more chronic and more severe illness. Some of the qualitative results, we had focus groups really focused around this issue of trust. How can I trust a system that has systematically oppressed me, whether I'm thinking about that consciously or subconsciously? We know that this issue of medical mistrust, which is not, the onus is not on the Black community the responsibility is not on the Black community to address these issues first and foremost. The responsibility is on these health systems that have been built with white people in mind. And that is a fact, and that is the truth. And so when Black people are approaching these health systems and they feel this distance, this, confusion and fear that, can I trust this doctor to give me this medication because they really care about me, or they just want to over-medicate me so that I don't come and ask, for any support from them. And we see that in things like treatment of psychosis for Black people in this community. So trust was a big issue. I'll just read a couple of quotes here. Some people in this study, in this focus group, which was focused around Black immigrants, talked about psychologically it's trauma. We're being traumatized here. And they say, America is the land of everybody. It is a land of immigrants. We're not being treated like that. You don't want us. Every time ringing in our ear that you are not wanted here. And so all of these political issues that we talk about, they're not separate from the experience people have in a doctor's office. So when we're talking about the Haitian immigrants at the border, more recently in the United States, and the way the Haitian immigrants, or migrants rather, at the border were treated, that impacts how people view our health systems. And you see that in this quote that predates, those occurrences that happened more recently. There's questions about representation, the lack of representation in our healthcare system, in our mental health care system, the lack of Black psychiatrists and psychologists and social workers and nurses and nurse practitioners. There are very few Black women or African women in this field who understand where we're coming from. And there's nobody to represent us to understand how to even, care for us. So where do we go from here? I think Dr. Stewart started us out with such great ideas around transparency, intentionality, commitment. And I want to continue to echo that in terms of things like getting involved. This organization is here, and there are organizations in the US, in the UK, but this organization is here. Get involved, know that you matter, that sometimes a patient out there won't take medication from someone else. They're going to take it from you because you understand their lived experience, and that you matter to your patients, staying engaged, finding community. And I think there's several opportunities here to do that. And I think I just want to end on this note, this idea of knowing your role in the movement for equity. It is a movement, it is happening. I love that Dr. Burke talked about a number of warriors who were treated in 1985. That's 36 years ago. Now imagine 36 years from now if we choose not to retreat and we choose to continue to fight for equity unrelentingly. And while it's exhausting and it's tiring, it's worth it, and it is going to make a difference for the next generation. So I'm going to end on that note, and grateful to the Association of Black Psychiatrists and Dr. Obinwa for the invitation.